in gallbladder, and that is biliary injury. And it's a very important topic for your exam. Now, first of all, what is the most common cause of biliary injury? The most common cause of biliary injury is iatrogenic. Most common cause of biliary injury is iatrogenic. Which iatrogenic? What iatrogenic reason? Which surgery? Cholecystectomy. So this injury can happen in laparoscopic cholecystectomy. This injury can happen in an open cholecystectomy. It happens in laparoscopy. It happens in open also. Out of laparoscopy and open, it is more common in laparoscopic cholecystectomy, right? Then in CBD injuries, we have to understand there can be two scenarios, and they can check you on any one of them. One is that the surgeon is doing cholecystectomy and he injured CBD and he knows he has injured it, right? Second is surgeon is doing cholecystectomy, he injured CBD and he doesn't know that he has injured it. CBD इंजरी हुई और पता है हो गई, CBD इंजरी हुई और पता भी नहीं है कि नहीं हो गई. So what to do when the injury happens intraoperatively? Means what to do when you come to know that the injury has happened. So in this scenario, if there is a minor injury to the CBD like this, we will do primary repair of CBD over T-tube. If it's a major injury to the CBD, what is major injury? Is it like this? What suture material are you going to use for CBD repair?
Yes.
It is micro. Stone formation, micro. So if it's a major injury, we will do Ru and Y hepatico-jejunostomy. What suture are you going to use for hepatico-jejunostomy? आज के सारे PDS से होना सकते. Vicryl. Okay. Now this was when the injury happened during surgery and the surgeon knows that the injury happened. मैंने पूछ ले तो दिल में आया. हाँ? So suture तो नर्स पकड़ा देती है, तो उसको पता है तो हमें क्या करना है? सर्जन को बना दो डॉक्टर और नर्स को बना दो डॉक्टर. Now, then comes what happens when the injury has happened and the surgeon doesn't know that it has happened. So who will tell the surgeon? Patient बोलेगा मेरी CBD कट के देखो जरा. Yes, patient will break this news. And how? This is a CBD. Imagine this is the abdomen, and during surgery, the CBD got cut. There will be bile leaking out. So the patient will come to us with features of biliary peritonitis. patient will come to us with features of biliary peritonitis. What are those features? Pain, right upper abdomen. Starting in the pain in the right upper abdomen. Patient will have vomiting. Patient will have distension. Can have obstipation also. On examination of these patients, you will find tenderness. There can be guarding. There can be rigidity also. So, what will you do immediately? Huh? We'll keep the patient perorally. Start IV fluid, IV antibiotic, and IV anti-inflammatory drug. And you can appreciate this, please appreciate this point, that more often than not, this patient कितना अच्छा पिरो के लिखा, उसके बाद भी कुछ distension. Now you can appreciate this cholecystectomy has happened and the patient is in post-operative period. So you can appreciate that this all must have been already running. Agreed? Now, how will you know now that there is an injury? What first investigation should we do? Any biliary pathology suspicion? We will do ultrasound. We will do ultrasound. And moment you come to know on ultrasound, there is a collection in the Morrison's pouch. There will be collection in the Morrison's pouch. Agreed? Yes. So we should immediately, before we proceed to any other thing, we should immediately put in a drain, percutaneous drainage. One should immediately do a percutaneous drainage. We have to remove this source of infection immediately. So one should do a percutaneous drainage. Right? And after this, we will do MRCP. And after MRCP, we will do endoscopic stenting. यहाँ पे आपको सेंटिंग ही करना. So this patient, what we are going to do, we have done this. Please understand this. आपने drain डाल दिया. After putting in a drain, we are going to endoscopically put in a tube inside into the CBD. So once you put in a tube inside the CBD like this, the bile will come through this tube. Bile is going to come through this tube and it will not come into the peritoneal cavity. So the treatment of CBD injury is endoscopic stenting. But how will you do that? The stepwise thing is this. First, we will do ultrasound. If there is a collection, we put a drain. After that, we will do MRCP and then we do endoscopic stenting. Right? So this is how we go about in CBD injuries. Okay. Then comes carcinoma gallbladder. Most common site Most common type. Most common site is fundus. Most common type is adenocarcinoma. There was a question asked in exam, which part of the world has a maximum prevalence of carcinoma gallbladder? India. Most common place where the carcinoma gallbladder is seen is India, followed by Pakistan. तो हमें इस बात का दुख नहीं है कि हम सबसे आगे हैं, हमें इस बात की खुशी है कि पाकिस्तान से ऊपर, और अभी मौका भी आने वाला है. Risk factor. The most important risk factor, very commonly asked question of carcinoma gallbladder is gallstone. The most important risk factor for carcinoma gallbladder is gallstone. And the other risk factors are porcelain gallbladder. Few risk factors are important for us. ये तो क्वेश्चंस का वो था बाप. Porcelain gallbladder, gallbladder polyp, and carcinoma gallbladder is also common in those who work in rubber industries. These are the important risk factors which we should be aware of. Now, I am slightly deviating away from the topic, but it is important. Gallbladder polyp. In case of a gallbladder polyp, important point, gallbladder polyp is a risk factor for carcinoma gallbladder. And the most common type of polyp in gallbladder is cholesterol polyp. And gallbladder polyp, if it is asymptomatic, but if it is more than 1 centimeter in size, or there is documented increase in size is there, documented gradual increase in size is happening, or once the patient is symptomatic, whatever the size may be, we are supposed to offer cholecystectomy. Once the patient is symptomatic, whatever the size may be, once the patient is asymptomatic, but size of it is more than 1 centimeter, or there is a documented increase in size happening, in such patients, even if the patient is asymptomatic, we have to offer cholecystectomy as a treatment for gallbladder polyp. Now, coming back to carcinoma gallbladder, most common presentation. Most common presentation of a patient of carcinoma gallbladder is pain, right upper abdomen. Patient can also come to us with loss of appetite or weight loss. Patient can also come to us with lump. An important point to note, a question already asked, jaundice. in a patient of carcinoma gallbladder is a late feature. Jaundice in a patient of carcinoma gallbladder is a late feature. Okay, and first investigation will be investigation of choice will be CT scan. Right? Now, in carcinoma gallbladder, management is important for us. So in management, again, I'll give you a very simple way of management here. In management of carcinoma gallbladder, we have option of surgery, we have option of chemo. We have option of surgery and we have option of chemo. Right. Now in surgery, we have two types of surgeries. Simple chole, radical or extended chole. In radical or extended cholecystectomy, we remove gallbladder with 2 centimeters of liver with regional lymph nodes. In radical or extended cholecystectomy, we do gallbladder removal with 2 centimeters of the liver margin with regional lymph nodes, which is also called removal of segment 4B and 5 of the liver with regional lymph nodes. Segment होते हैं ना liver में. Right? Now, what to do when? This is important. Just remember this. T1, no need to go into the detail. Just remember this. T1 is invasion of lamina propria and or muscularis. T1 is invasion of lamina propria and or muscularis. This is T1A, this is T1B. This question very commonly comes in our exam. T2 is invasion of perimuscular connective tissue. Invasion of lamina propria and or muscularis. T2 is invasion of perimuscular connective tissue. Okay. Now, if you are asked, what is the treatment of stage 1 carcinoma gallbladder? What is stage 1? T1, N0, M0. Stage is T, N, and M. If it is T1, N0, M0, it is stage 1. Your answer should be open, simple cholecystectomy. But please remember this. If it is T1A, N0, M0, what stage is it? Still stage 1? Your answer will again be this. But please be careful in this. If you are told that there is a muscularis invasion in a given patient, if there is a muscularis invasion mentioned in a given patient, what stage is it? What is the stage? Stage 1. Still stage 1. Why 1B? 1B is for T. Stage is T and N. स्टेज होती है 3 चीजों को मिला के बनती है, T, N और M. मैं पूछ रहा हूं स्टेज क्या है? So answer for this, though this is the stage 1 still, but since muscularis invasion provided in a given question, so your answer will change to radical coli. Once they provide you muscularis invasion, though it is still stage 1, answer will be radical cholecystectomy. If it is stage 2, that is T2, sorry, N0, M0, it is radical cholecystectomy. It is radical cholecystectomy. Right? Now, for remaining whatever left now, your answer should be chemotherapy. It will be chemotherapy. Right? Now, so if I ask you, what is the treatment of advanced carcinoma gallbladder? If I ask you, what is the treatment of carcinoma gallbladder invading adjacent structure? Chemoradiation? कुछ भी. Chemotherapy, right? Now, so that way you'll answer. Okay, now, most important risk factor for carcinoma gallbladder is gallstone. Most important risk factor of carcinoma gallbladder is gallstone. Now, many times what happens is, the surgeon has done a cholecystectomy for gallstones. जब surgeon cholecystectomy कर रहा था, he thought he is dealing with gallstones. But when the gallbladder was removed and sent to the pathologist, you came to know that there is a malignancy also inside. So what to do when the cholecystectomy is already done? So after cholecystectomy, if you come to know about carcinoma gallbladder after cholecystectomy for gallstones, what to do? So if after cholecystectomy for gallstones, it was told that it is stage 1, what will be the treatment? Nothing required. cholecystectomy तो हो गई है, अब क्या पड़ोसी की निकालेंगे? Nothing doing, right? If you are told that it is T1A N0 M0 after cholecystectomy, nothing doing. But if you are told it is T1B N0 M0, now gallbladder is already removed. So that means we have to do the remaining job of radical cholecystectomy. That is 2 centimeters of the liver with regional lymph nodes. If you are told it is T2 N0 M0 or stage 2, the same. Remaining job of a radical cholecystectomy. अब कीमो करनी पड़ेगी. अब गॉलब्लैडर वापस तो रखते नहीं आ सकते. राइट। अब ये भी नहीं बोल सकते तुम्हारा कुछ सामान हमारे पास पड़ा है। ओके, सो दिस इज हाउ वी मैनेज carcinoma gallbladder. Then comes coledocal cyst. What is coledocal cyst? Abnormal dilatation of biliary channel. Abnormal dilatation of biliary channel is coledocal cyst. And there's a classification for coledocal cyst which we have to know, comes by the name of Todani's classification. So Sindhi hai. Todani's classification. In that, type 1 is Dr. Vikas se पूछना पड़ेगा. Type 1 is the most common. Type 1 is the most common. And in that, there is a fusiform dilatation of common hepatic duct or common bile duct is there. Type 2 is diverticulum from common hepatic duct or common bile duct. Type 1 is like this. Type 2 is like this. Right? Type 3 is intramural part of CBD dilatation. Intramural part of CBD dilatation in duodenum. Intramural part of CBD dilatation in duodenum. It is also called coledococcene. Type 4 is intra and extra hepatic part of biliary dilatation. Type 5 is only intrahepatic part of biliary dilatation, and this is also called Caroli's disease. Okay, now most common age of presentation of this condition is it commonly present at a pediatric age group. Most common presentation of these patients, they commonly come to us with jaundice. They can also come to us with pain. They can also come to us with mass. So there can be triad also in these patients of pain, jaundice, and mass. Most common complication of this condition is acute cholangitis. And very important point, choledochal cyst is a risk factor for 5 malignancies. Choledochal cyst is a risk factor for 5 malignancies. What are those 5 malignancies? Important. CBD, gallbladder, pancreas, liver, duodenal. These are the 5 malignancies it is a risk factor for. It can lead to congenital क्या? This is a congenital problem, but it presents at an age of pediatric age group. Means 10 to 14 years से पहले these patients usually come to us. First investigation is, what will be the first investigation? Investigation of choice is gold standard is, and the treatment of this condition is always excision. Treatment of this condition is always excision. And there was a question asked, why choledochal cyst is always excised? The reason is because it can lead to malignancy. So these are the things we need to know in gallbladder. Now, any question? Then comes pancreas. Now, in pancreas, first of all, what is the most common anomaly of pancreas? What is the most common congenital anomaly of pancreas? The most common congenital anomaly of pancreas is pancreatic division. Most common congenital anomaly of pancreas is pancreatic division, followed by annular pancreas. Very commonly asked question. Now, this annular pancreas actually needs a special mention, right? In this annular pancreas, what happens is there are 2 pancreas on either side of the duodenum. In this condition, you have 2 pancreas on either side of the duodenum. Okay. Now, how does these patients present? The most common presentation of these patients is duodenal obstruction. Most common presentation of these patients is with features of duodenal obstruction. Now, very important point, this condition and one more condition get commonly confused. What is that other condition which get confused with this condition? And that condition is duodenal atresia. Duodenal atresia and annular pancreas both have a common presentation. Both will present to us with in newborn phase with vomiting. Now, important point to note in this vomiting is that in annular pancreas, important point, more commonly there is a non-bilious vomiting, while in case of duodenal atresia, we commonly have a bilious vomiting. And in both these conditions, on X-ray abdomen, if you do, you will get a double bubble sign, right? And this can be a question in your exam. Please understand this. Any patient, any newborn, as a rule, we should know this approach. Any newborn, if comes to us with a vomiting and on X-ray abdomen, we find a double bubble sign, we are always supposed to rule out first duodenal atresia. We have to always first rule out duodenal atresia. So that means our next investigation will be to diagnose duodenal atresia. And what will that be? Upper GI contrast study. And if on upper GI contrast study, it confirms it's a duodenal atresia, we will manage duodenal atresia. But if on upper GI contrast study, it rules out duodenal atresia, then we will investigate on the lines of annular pancreas. So what will we do then? After this, what is the investigation of choice for annular pancreas? MRCP. So इसका मतलब क्या हुआ? कोई भी न्यूबॉर्न अगर डबल बबल साइन एक्सरे में मिलेगा, you will first do upper GI contrast study. If upper GI contrast study is normal, then you will do MRCP. Okay, and the treatment of choice for both these conditions is DD or DJ or DDLJ. DD. What is DD? Duodenostomy. Duodenostomy. What suture you are going to use? Yeah, PDS. आज कुछ तो बोलोगे, right? Duodenostomy. Now, then comes acute pancreatitis. Now, can you tell me what is the most common cause of acute pancreatitis? The most common cause of acute pancreatitis is gallstones. The most common cause of acute pancreatitis is gallstones. But then there are few important causes which we have to know. Alcohol, trauma, ERCP, hyperlipidemia. These are the important causes we need to know. Hyperlipidemia, hypercalcemia, important. Hypercalcemia can also lead to acute pancreatitis. Viral infection. Now, can anyone tell me which viral infection most commonly leads to acute pancreatitis? It is mumps. Very good. It is mumps. Right? Then, now let's understand, please try to understand what is happening in acute pancreatitis. Once you understand this, one more risk factor we should know, hereditary. Pancreatitis can be hereditary. Can gallstone disease be hereditary? No. Answer is yes, it can be hereditary. Okay. Now, let's understand the pathophysiology of acute pancreatitis. Once we understand the pathophysiology, it will be easier for us to remember how a patient of acute pancreatitis is going to present. Okay. See, you all know pancreas is an organ which helps in digestion of fat. Right? And you should know that pancreas itself is made up of fat. So, why pancreatic enzyme never digests its own fat?
So they're inactive inside. They are inactive.
Because they are released in an inactive form, and which requires activation inside the intestinal lumen. So it never digests its own fat. But what happens is, when the acute pancreatitis happens, this is a very important understanding. When the acute pancreatitis happens, these enzymes released in an active form, not only in the substance of the pancreas, but also around pancreas and inside the intestinal lumen also. So whatever fat they come across, they start digesting it. So the immediate fat they come across is its own fat. So it digests its own fat. This is the only organ whose inflammation leads to autodigestion. So pancreatic substance get digested. Not only it will digest, means that pancreatic substance, when once get digested, get necrosed. So not only it is digesting its own fat, it will digest whatever fat it is coming across. So pancreas is behind the peritoneum. You all know it's a retroperitoneal organ, and peritoneum itself has a fat. So it digests peritoneal fat also, and once it digests peritoneal fat, the peritoneal inflammation happens. So the patient can develop peritonitis. So that means because of pancreatitis, there can be peritonitis. Right? And pancreas is surrounded by many vessels. All retroperitoneum is full of vessels. So all these vessel linings are also have a fat in them. So it can digest their fat also. When it digests the fat of the lining of the vessel get eroded, and there will be a bleeding also. So that means in a patient of acute pancreatitis, there can be a retroperitoneal hemorrhage, there can be intra-abdominal hemorrhage also. So depending on how severe is the attack of acute pancreatitis the patient has, the presentation of the patient can vary. It is quite possible, if the attack of pancreatitis is very mild, patient may just have a pain in the epigastric region. But if the attack of acute pancreatitis is quite severe, it is quite possible that the patient may present to us with features of peritonitis. So any which way a patient of pancreatitis can present. Now, what is another important thing for us to understand is, whatever part gets digested, means necrosed, depending on how severe was the inflammation, it is quite possible that whole pancreas may get digested. And it is also quite possible that only small patch of the pancreas may get digested. But whatever part of the pancreas once get digested, that part of the pancreas loses its function, both exocrine and endocrine. So it is also possible, you can make out from here, that after a single attack of acute pancreatitis, if whole pancreas got necrosed, so the patient after an acute attack once improves, doesn't have a pancreatic function at all. So it depends on how severe was the attack. Accordingly, the later sequelae will be there, right? So with this understanding, now we can relate what I'm going to write down in presentation of a patient of acute pancreatitis, right? Now it will be easier for you to remember these things. Now the most common and characteristic, very, very important point, most common and characteristic presentation of patient of acute pancreatitis is pain, epigastric region, radiating to back, getting relieved on bending forward. This is the most common and a characteristic presentation. Patient can also present to us with vomiting. Patient can also present to us with distension. Patient can also present to us with obstipation. Why all this is happening, we can make out. On examination of these patients, we may have tenderness. We may have rebound tenderness. We may have guarding. We may have rigidity also. And there can also be, and why this is happening, you can now relate. And one can also have Gray Turner or Gray Turner or Cullenstein. What is Gray Turner or a Cullenstein? तुम लोगों सर कैपिटल में भी इतना खराब लिखते, मतलब लोग कैपिटल में तो ठीक लिख देते हैं, आप तो कैपिटल में भी. Gray Turner and Cullenstein. Gray Turner sign is bluish discoloration around flank. Cullenstein is bluish discoloration around umbilicus. And very important for you to note, these are not the signs specific to acute pancreatitis. These signs are going to be there in any condition where there is an intra-abdominal hemorrhage. Any patient who has a hemoperitoneum, for whatever reason, can have these signs. So since in acute pancreatitis there can be hemoperitoneum, we can have these signs. Okay, now Gray Turner sign and a Cullen sign. सेम कैसे भाई? Gray Turner, Cullen. मेरी गलती है, ठीक है, सॉरी। कैसे हुआ? वेसल को इरोड किया, उससे ब्लीडिंग हुई। नाउ कैन यू टेल मी what is the investigation of choice for acute pancreatitis? Investigation of choice for acute pancreatitis is serum amylase and serum lipase level. एक्यूट पेनक्रेटाइटिस सबसे लेट डायग्नोज होता है, क्यों? सीए पेनक्रियाज और एक्यूट पेनक्रेटाइटिस दो अलग अलग बातें भाई। अरे सीए पेनक्रियाज है, वो लेट डायग्नोज होता है, तो एक्यूट पेनक्रेटाइटिस को लेट डायग्नोज होगा। नोएडा पहुंचने में ज्यादा टाइम लगता है, तो यूसुफसराय पहुंचने में जरूर थोड़ी ज्यादा टाइम लगेगा। यूसुफसराय है नोएडा। अब सीए पेनक्रियास को अगर टाइम ज्यादा लगता है डायग्नोज करने में, तो एक्यूट पेनक्रेटाइटिस का क्या लेना देना उससे? है तो दोनों पेनक्रियास। इन्वेस्टिगेशन ऑफ चॉइस फॉर acute pancreatitis is serum amylase and lipase. And very important point to notice, most sensitive biochemical marker, very commonly asked question, of acute pancreatitis, if asked, it is as per the latest serum lipase. Most specific biochemical marker of acute pancreatitis, if asked, it is also serum lipase. Serum amylase can get raised in other conditions also, like checked in exam, salivary gland inflammation, ectopic pregnancy, hollow organ perforation, mesenteric ischemia, intra-abdominal organ torsion. These are the conditions where serum amylase may get raised. Right? Now, very important point, investigation of choice for acute pancreatitis is serum amylase and lipase though. But highlight that in your notes, that level of serum amylase and lipase has nothing to do with severity of acute pancreatitis. So a patient who has a 500 amylase, a patient who has 1,000 amylase, doesn't mean the one who has 1,000 amylase has a more severe attack. They are just marker of acute pancreatitis. Their level has nothing to do with the severity. They are just marker of acute pancreatitis. They don't have anything to do with the severity. Okay, now the gold standard investigation for acute acute pancreatitis is CT scan. The gold standard investigation for acute pancreatitis is CT scan. Right? But CT scan, please highlight again. For CT scan in acute pancreatitis should only be done after 72 hours. It should not be done before 72 hours. CT scan in acute pancreatitis should be done after 72 hours, not before that. Because even if you do, even if there is acute pancreatitis, if you do CT scan within 72 hours, CT scan will not be able to show the features of acute pancreatitis. It takes 72 hours for the features of acute pancreatitis to be seen on a CT scan. तब तक ट्रीटमेंट के लिए हमारे पास हमारे लाइफ है ना, राइट. अब एक काम करते हैं, हम चीजें लिखते जाएंगे और उसके बाद हम समझेंगे. ठीक है, पहले हम लिखेंगे, लगातार लिखते जाएंगे, किसी से कुछ नहीं पूछेंगे ना बात करेंगे, और फिर हम इसको समझेंगे जो हमने लिखा है. ठीक है, हम स्लो लिखेंगे. ठीक है. नाउ द मोस्ट कॉमन कॉज ऑफ अर्ली डेथ in acute pancreatitis is multi-organ failure. Most common cause of late death in acute pancreatitis is sepsis. Most common cause of early death in acute pancreatitis is multi-organ failure. Most common cause of late death in acute pancreatitis is sepsis. And if you are asked what is the most common cause of death in general, it will be sepsis. First line of management. First line of management in acute pancreatitis is keeping the patient nilpar only, IV fluids, IV anti-inflammatory drugs. Just keep writing, we'll understand this. सिर्फ लिखते जाओ, पूछेंगे नहीं, बोलेंगे नहीं, कुछ नहीं करेंगे. Right? Indications of surgery. Indications of surgery in acute pancreatitis are infected pancreatic necrosis, infected pancreatic necrosis, or when there is more than 50% necrosis of the pancreas. When more than 50% necrosis of the pancreas is there, then also we will do surgery. Right? Then most common complication of acute pancreatitis, most common complication of acute pancreatitis is peri-pancreatic fluid collection, peri-pancreatic fluid collection. If not there in your choice, then pseudo cyst of pancreas. If not there in your choice, then it is pseudo cyst of pancreas. Then to assess severity of pancreatitis, to assess severity of acute pancreatitis, we have various scores to assess the severity of acute pancreatitis. We have various scores like Ranson score. If the Ranson score is more than or equal to 3, if the Ranson score is more than or equal to 3, it suggests severe pancreatitis. We have Apache 2. Apache, not Yo-Yo Honey Singh. Apache 2, if it is more than 8, घर जाके समझेंगे. When it is more than or equal to 8, then also it is severe acute pancreatitis. It also suggests severe. C reactive protein index, if it is more than 150 milligram per deciliter, it also suggests severe acute. We have to know what is severe pancreatitis. So these scores are telling us the severity of acute pancreatitis. We have modified Atlanta score also. We have to know the names of these scores and their values also. If it is more than 1, it suggests a severe pancreatitis. Now, out of all these scores, we have to know the parameters in Ranson score. Important. Ranson score parameters are important for us. In Ranson score, the parameters at the time of admission are there. The parameters within 48 hours are there. At the time of admission and within 48 hours. So what are the parameters at the time of admission? We don't need to know their value, not required. We just need to know whether their increase or decrease is suggesting severity. This is a very commonly asked question. So we should know whether the increase of these parameters is suggesting severity or decrease of these parameters is suggesting severity. So age. If the patient has an increasing age, elderly patients have chances of more severe attacks. TLC count, if it is more, suggests severity. Blood sugar, if it is more, suggests severity. LDH, not MDH. If it is more, suggests severity. AST level, if it is more, suggests severity. Now, very, very important point, hematocrit. Hematocrit decrease suggests severity. Serum calcium decrease. Please highlight this point in notes. Hypercalcemia leads to acute pancreatitis. Hypocalcemia happens in acute pancreatitis. Hypercalcemia leads to acute pancreatitis. Hypocalcemia happens in acute pancreatitis. Any patient has a more fluid requirement. Any patient having more fluid requirement suggests severity. Decreased PaO2 suggests severity. Increased blood urea nitrogen suggests severity. So these parameters are important for our exams. Whether their increase or decrease is suggesting severity, we have to know. Okay. So this was a theoretical point, okay, which you have all written now. Let's understand. Blood urea nitrogen. Now let's understand this. Okay. देखो क्या है? Acute pancreatitis. When acute cholecystitis happened, we could manage by doing cholecystectomy. When acute appendicitis happens, we can manage by doing appendectomy. Once acute pancreatitis happens, we just cannot think of removing pancreas. So surgically, in acute pancreatitis, we are handicapped. We can't think of doing a pancreatectomy, right? God has placed pancreas in such a deep location, at such a strategic position, that it itself says, don't mess with me, right? So even when there is no problem to pancreas, if we try to remove pancreas, there are so many complications. Leave alone when the pancreas is inflamed. So most of the time in acute pancreatitis, we are left with no choice but to offer a conservative management. Surgery has a very limited role. The maximum we can do in surgery in pancreatitis is necrosectomy, because necrosis is happening here. So we can maximum offer a necrosectomy to the patient. Nothing more than that we can offer to a patient of acute pancreatitis. Now, सबसे important बात आती है कि हम acute pancreatitis को diagnose कैसे करते हैं. पहले हमें diagnose करना होगा, फिर diagnose करने के बाद हमें ये assess करना होगा कि कितना severe attack है. Severity के बाद हमें ये assess करना होगा कि अब इसको manage कैसे करें. Understood? तो हमें तीन बातों को ध्यान रख के pancreatitis के patient में we will progress. Okay. Now, how are we going to diagnose? Remember, this will be a clinical profile to you. So, what clinical profile should trigger you to think about a pancreatitis? You should know. Any patient once told to you is coming to you with a pain epigastric region radiating to back. Always think about acute pancreatitis. One. Any patient, if told to you, is coming to you with a pain epigastric region, not radiating to back this time, pain epigastric region, but with features of peritonitis. If you can recall yesterday, we talked about once a patient comes to us with pain epigastric region with features of peritonitis, two things are to be ruled out. Peptic perforation and pancreatitis. So, in any given question, once you have a pain epigastric region radiating to back or pain epigastric region with a features of peritonitis provided, we have to think about pancreatitis always. Okay, now since acute pancreatitis, please understand this, every point which I have written has a meaning and has a relevance which you gradually will understand. Now, acute pancreatitis is an acute GI condition, yes or no? But what is very important to appreciate in acute pancreatitis, you have written it also, that most common cause of early death is multi-organ failure. Most common cause of late death is sepsis. So that means it's an acute GI condition but it is not acute infective GI condition at the outset. Initially, this is not an infective condition, but over a period of time, it may become infective because once the necrosis happens, initially the necrosis will happen, and you all know necrosis is a very good breeding ground for microorganisms. So over a period of time, the microorganism will start growing. So in initial stages, there is no microorganism, so it is not an infective problem, but it's an acute problem, right? So our approach will be acute GI approach, but it will not be acute infective GI approach. Okay, now please everything अगर नहीं समझ आया तो बोलना होगा. आपके पास पेशेंट आया, पेन एपिगेस्टिक रीजन radiating to back और पेन एपिगेस्टिक रीजन विद अ पेरिटोनाइटिस. अब आपके सामने दो चॉइसेस हैं. आपके पास या तो ये पेप्टिक अल्सर परफोरेशन है या ये पेनक्रेटाइटिस है, राइट? आपको नहीं पता ये पेनक्रेटाइटिस है या फिर पेप्टिक अल्सर परफोरेशन है. तो हम सबसे पहले ये मान लेते हैं कि दिस इज एन एक्यूट इन्फेक्टिव जीआई कंडीशन. we take it for granted that it's an acute infective GI condition. So what we will do, we will keep the patient nilperorally, we'll start IV fluid, IV antibiotic and IV anti-inflammatory drug. ठीक है, अब हमने ये सबसे पहले शुरू कर दिया. अब हमें साइमल्टेनियसली ये पता लगाना है कि क्या ये पेप्टिक अल्सर परफोरेशन है या ये पेनक्रेटाइटिस है. तो इसका मतलब है हमें दो इन्वेस्टिगेशंस करनी पड़ेगी. वन इज अ चेस्ट एक्सरे. इफ यू कैन रिकॉल, फॉर पेप्टिक परफोरेशन वी डू चेस्ट एक्सरे एंड फॉर पेनक्रेटाइटिस वी विल डू amylase and lipase. Now if it on chest x-ray turns out to be a gas under the dome of diaphragm, we will go towards a peptic ulcer perforation. Understood? But if chest x-ray doesn't reveal a gas under the dome of diaphragm, but serum amylase and lipase are raised 3 to 5 times normal, it is acute pancreatitis now. अब ये acute pancreatitis है. अब जैसे हमें पता लगा acute pancreatitis है, we can stop this antibiotic. No need of giving antibiotic. Even if you have started, you can stop it, right? And we also know by now that in a patient of acute pancreatitis, surgically we are handicapped. So as far as possible, we will try to manage our patient with this. Jitna possible hoga, we will manage with this. Now in this management which we have written, the most important thing a question asked is fluid. So the most important thing in management of a patient of acute pancreatitis is fluid, because that is the only thing. This supportive treatment is the thing, and in this supportive treatment, most important thing is fluid. And in fluid, the fluid of choice is ringer liquid. Question asked. And after fluid, the second important thing is anti-inflammatory drug, right? Because in initial phases, the multi-organ failure happens because of the inflammation. Antibiotic has no role. Please note, antibiotic in acute pancreatitis has no role in initial stages, right? Now, after this, the third important thing, very, very important point, is nutrition. Now, you have kept your patient nilperorally. How will you provide nutrition? The guideline says, listen to this. The guideline says you should provide nutrition initially through total parenteral nutrition, means through IV line provide the nutrition, and movement in a patient of acute pancreatitis, the bowel sound comes. Bowel sound comes. Patient has obstipation, remember. What is obstipation? No feces, no fetus. flatus. So this patient, movement bowel sound comes. The guideline says stop TPN, total parenteral nutrition you can stop, and now you can start Riles tube feeding to the patient. You should put a Riles tube and through Riles tube start feeding. So this treatment which we have started is the treatment, and we try to manage acute pancreatitis with this treatment alone. Right? Up. You are continuing to manage this patient with this treatment. Okay. Now, if in further management, the necrosis gets infected, if the necrosis is more than 50%, if the necrosis is getting infected, or if the necrosis is more than 50%, you will do surgery. What surgery? Necrosectomy. अब ये पता कैसे लगेगा कि necrosis infect हो गया और more than 50% है? We will get to know this by CT scan. CT scan में आपको necrosis दिखेगा और CT scan में आपको infection भी पता लग सकता है if you take a aspiration of the necrosis. और CT scan कब करना है ये देखने के लिए? After 72 hours. After 72 hours. And out of all the types of acute pancreatitis, the best prognosis is of gallstone induced pancreatitis. Best prognosis is of gallstone induced pancreatitis, and the most common complication of acute pancreatitis is peripancreatic fluid collection followed by pseudocyst of pancreas, which I have already written. ये approach understanding of acute pancreatitis was very very important for you. Nowadays तुमने जो theoretical बातें लिखी हैं, they are not mainly checking on that. They check you on these clinical ways. कि क्या करेंगे, क्या patient आएगा तो क्या करने वाले? They are not going to check you what is the most sensitive marker of acute pancreatitis. They are not going to check you what is the most specific marker of pancreatitis. We should know. That's a different thing. They will ask you that करोगे क्या? Patient आपके पास आया, pain epigastric region radiating to back. Which are the following investigation you'll do? You should know that in such patient you have to rule out peptic perforation and chest X-ray. If it is peptic ulcer perforation, how to proceed? We should know. If it's a pancreatitis, how should proceed? We should know. समझ आया कि बाउंसर गया? पक्का? Okay. Now, then comes pseudocyst of pancreas. Pseudocyst of pancreas. Now, why this cyst is called pseudo? A question asked. Why this cyst is called pseudo? Why it is called pseudocyst? The reason of this being called pseudocyst, because the lining wall of this cyst is made up of fibrous tissue. lining wall of this cyst ये क्या हो रहा है? Lining wall of the cyst is made up of fibrous tissue, not epithelial lining. Now, the most common location of this pseudocyst, a very commonly asked question. The most common location of the pseudocyst of pancreas is lesser sac. Most common location of the pseudocyst is lesser sac between posterior wall of stomach and body of pancreas. So this is a cyst like this. Right? Now, can you tell me what can be the complications which this cyst can lead to? Considering the way the cyst is, can you make out what all complications this cyst can lead to? One is infection. This cyst may get infected. Second, this cyst may cause obstruction. And third, this cyst may get rupture also. So these are the common complications of this pseudocyst, where infection is the most common complication. Where infection is the most common complication. Okay, now pseudocyst of pancreas is a sequelae of acute pancreatitis. We have seen that, right? And most of the time, most common sequelae of pseudocyst is spontaneous resolution. So most of the time what happens is acute pancreatitis happens, pseudocyst develops and it gets on its own resolved. So there was a question asked, what is the most common sequelae of pseudocyst of pancreas? Answer is spontaneous resolution. So it usually gets resolved on its own. But sometimes it fails to get resolved. And once it fails to get resolved, we are supposed to do something. So what are the indications of intervention in pseudocyst? Usually we don't need to intervene because it usually resolving on its own. But once it is not resolving on its own, we are left with no choice but to intervene. So when to intervene? One, when it is there for more than 6 weeks. If it is there for more than 6 weeks, it is not going to resolve now. You have to do something about it. Second, if it is more than 6 centimeter in size. If it is more than 6 centimeter in size, again, it is not going to resolve on its own. You can take it for granted. And third, if it is causing complications. These are the indications of intervention in pseudocyst of pancreas. Right? Now comes, how will you intervene? What are the ways of intervention? There are 2 ways of intervention. Internal drainage, external drainage. What do you mean by internal drainage? What do you mean by external drainage? External drainage का मतलब है, ये एब्डोमेन है, आपने इस सिस्ट के अंदर ड्रेन डाल दी. It is external drainage. Putting a drain in the cyst from outside is external drainage. What do you mean by internal drainage? Internal drainage का मतलब होता है आपने इस cyst को neighboring organ में खोल दिया, स्टमक में खोल दिया, duodenum में खोल दिया, कहीं भी खोल दिया, but neighboring organ में खोल दिया. So there are two ways of treating this cyst: internal drainage and external drainage. A question asked, out of internal or external drainage, which is preferred? Internal drainage is preferred over external drainage, right? External drainage is only done. External drainage we don't prefer, but sometime we may need to do. Sometime we may need to do when when the cyst is infected. You should not drain infected thing inside the neighboring organ. You should drain it outside. Second, if the patient is too sick, patient can't withstand a surgical procedure, you have to do external drainage. And third, if the wall of the cyst is immature, if the wall of the cyst is immature, so in these three situations, we will do external drainage. Otherwise, we do internal. Now, internal drainage, there are two ways. In internal drainage, we have two ways. Endoscopic internal drainage. This is the latest. Endoscopic internal drainage and surgical internal drainage. Which one you will prefer? तो बजर राउंड लग रहा था मुझे. Endoscopic internal drainage is preferred. If endoscopic internal drainage is not possible, then only we now do surgical internal drainage. And in surgical internal drainage, we do cystogastrostomy. The surgery which we do is cystogastrostomy. Right? So this is what we need to know in pseudocystopancreas. Then comes, हमने स्टमक में खोल दिया. Usually stomach में खोल. Chronic pancreatitis. The last topic of the day. Chronic pancreatitis. Now, can you tell me what is the most common cause of chronic pancreatitis? Huh? The most common cause of chronic pancreatitis is alcohol. The causes of chronic pancreatitis are grouped into a classification called TIGAR-O classification. What TIGAR stands for, we just need to know that. T stands for toxic metabolites. I stands for idiopathic. G stands for genetic. A stands for autoimmune. R stands for recurrent. O stands for obstructive. T stands for toxic metabolites, I stands for idiopathic, G stands for genetic, A stands for autoimmune, R stands for recurrent, and O stands for obstructive. Now, in chronic pancreatitis, say there are going to be three problems in a patient of chronic pancreatitis. A patient who had an acute attack in past, subsequently will have a chronic pancreatitis. So there are going to be three problems in a patient of chronic pancreatitis, and you will yourself answer the question which I ask you at the end. There are three problems. The three problems are: one is a pain abdomen. The second problem in these patients will be exocrine dysfunction. And third problem is endocrine dysfunction. Because whatever part of the pancreas got digested in the past because of acute pancreatitis, that part will lose its both exocrine and endocrine function. So chronic pancreatitis patient can have a exocrine dysfunction, can have a endocrine dysfunction, can have a pain abdomen also. Now, very important point to note in this is exocrine and endocrine dysfunction. The features of exocrine and endocrine dysfunction in a patient of chronic pancreatitis will come up only when 75 to 90% of the pancreatic substance get digested. ये features तभी आने शुरू होते हैं जब 75 to 90% of the pancreas loses its function. तो तब तक जब तक 75% to 90% of the pancreatic substance doesn't lose its function, these features will not be there. So that means what is the most important feature in a patient of chronic pancreatitis will be, and the very classical thing about this pain of chronic pancreatitis is this pain is a persistent progressive pain. This pain is persistent and this pain is a progressive pain also. Important point. अब अगर exocrine dysfunction के features आएंगे भी तो क्या आएंगे? And ये तब आएंगे जब 75 to 90% pancreas damage हो जाएगा. तो क्या अगर damage हो गया तो क्या feature आएंगे? What exocrine function pancreas does? Digestion of fat. So there will be
Fat malabsorption.
steatorrhea. So how will you know that the patient is having a fat malabsorption leading to steatorrhea? Bulky, frothy, stool, which is difficult to flush. Bulky, frothy, stool, right? And if there is a endocrine dysfunction happening, what will be the presentation? Diabetes mellitus. So that means a patient of chronic pancreatitis can have pain, can have steatorrhea, can have diabetes, but most of the time what do they have? Pain, because steatorrhea and diabetes happens very late. So the most common and characteristic presentation of chronic pancreatitis is again same, that is pain epigastric region radiating to back. Pain epigastric region radiating to back is the most common and characteristic presentation of a patient of chronic pancreatitis. And you know now that the patient can also have steatorrhea, or diabetes mellitus also. Now coming on to what is the investigation of choice for this condition? Very commonly asked question, and there's a lot of confusion on this. It is now MRCP. While please be very careful if you are asked what is the investigation of choice in advanced chronic pancreatitis. Your answer should be then CT scan. Answer then should be a CT scan. But if gold standard investigation asked, gold standard investigation asked, it will be endoscopic ultrasound guided biopsy. If not in your choice, then ERC. Endoscopic ultrasound guided biopsy. If not in your choice, then ERC. Now in ERCP, very important point, you get a classical appearance called chain of lake appearance. And there is a criteria on ERCP, which is called Cambridge criteria. You don't need to go into the details, but you just need to know there's a criteria to diagnose chronic pancreatitis on the basis of ERCP, which is called Cambridge criteria, right? And similarly, there's a criteria to diagnose chronic pancreatitis on the basis of endoscopic ultrasound. Again, you just need to know the name. That is called Rosemont criteria. Okay, now then comes management. Then comes Rosemont criteria and Cambridge criteria. Now, in management of a patient of chronic pancreatitis, you all know that we may need to manage pain. We may need to manage exocrine dysfunction. We may need to manage endocrine dysfunction also. So if I ask you now, which is a very commonly asked question, and it is not going to be difficult for you now, what is the most important consideration in management? Pain. Again, pain. So we will talk about this pain management, but before that, we should know exocrine dysfunction management is not difficult because we can manage by giving exogenous pancreatic enzymes. If we give pancreatic enzymes on outside, you can take care of the fat malabsorption. Endocrine dysfunction, diabetes mellitus, again we know how to manage it. Now this pain management is very, very important for us to understand. I told you, this pain is persistent pain and it is progressive, right? So what happens in these patients, and this is how we always go about also. We start with NSAIDs. We start with NSAIDs. As this pain is progressive, it is quite possible after some time the NSAIDs will not be effective. Then we have to, please, they ask this question in this stepwise approach itself, that now the patient is not responding to NSAID, what will you do? You will switch over to non-opioid analgesics. If the patient is not responding to non-opioid also, after some time they will stop responding to non-opioids also. We switch over to opioids. And after some time, either the patient get addicted to opioids or will stop responding. In either of the situation, we are supposed to proceed to celiac axis ganglion block. Very important. This is a kind of chemical sympathectomy. This is the kind of chemical sympathectomy which you have to do. Now, after this, again, the pain comes back. After this also, but this effect will last quite long, but pain comes back. And once this pain comes back, it is now called intractable pain. This is now called intractable pain. Okay. Now in this intractable, once the pain becomes intractable, means it stops responding to any form of medical therapy. We are left with no choice but to offer surgery now. अब हमारे पास कोई ऑप्शन नहीं है. Now we have to offer surgery. And what surgery we are going to do now? This is important. The surgery will depend on very, very important point. Answer in your MCQ scores again as a problem. Which part of the pancreatic duct? You have to see in your given question. Which part of the pancreatic duct told to you is dilated? The surgery will depend on which part of the pancreatic duct in a given question told to you is dilated. If you are told distal part of the pancreatic duct is dilated, if you are told proximal part of the pancreatic duct is dilated, your management is going to be different. If the distal part of the pancreatic duct told to you is dilated, your answer should be distal pancreatectomy. Distal pancreatectomy. And if you are told proximal part of the pancreatic duct is dilated, then your answer should be lateral longitudinal pancreatico jejunostomy, which is also called modified Pusto's procedure. Modified Pusto's procedure. Now, what suture are you going to use for this anastomosis? It is, huh? Pancreatic duct stone बनते हैं, तो answer is Vicryl. It is Vicryl. And the most common complication of chronic pancreatitis, a very commonly asked question, is pseudo cyst of pancreas. Most common complication of chronic pancreatitis is pseudocyst of pancreas. Now, can you tell me, is chronic pancreatitis a risk factor for carcinoma pancreas? Yes or no? Yes. Answer is yes. Answer is yes. And this is all for today. We have to call it a day today because I have to go to the hospital and have a case there.